My name is Carl Nadolski. I am an endocrinologist in Holland, Michigan, and a diplomat of the American Board of Obesity Medicine. Oh, what's that? Okay, and I am joined by my younger brother, Spencer Nadolski. He is a diplomat of the American Board of Lipidology and a diplomat of the American Board of Obesity Medicine, and is currently the medical director for the Weight Watchers medical program. And today we were asked to talk about treating diabesity. Specifically, we'll be talking about treating obesity as the root pathophysiology of type 2 diabetes. And I'll talk about our objectives here in a second. We don't have any relevant financial multiplicities of interest. We're not paid by Big Pharma to push any of their drugs. Spencer gets paid by Weight Watchers to maybe use the medications and help people with their overall lifestyle. So mostly we're going to go through several slides, just really hammering home the concept that obesity and adiposity is really the root driving force of type 2 diabetes and all the complications, including of interest to lipidologists, the dyslipidemia and the elevated cardiovascular risk. Certainly, we are the hosts of our own DoxuLift podcast. We have been shills for nutrition and exercise our whole lives. That's what got us into these specialties. So we will certainly talk about some nutrition and physical activity recommendations for obesity complicated by type 2 diabetes. And then we'll get into some of the medications and some of the data behind using them for treating the obesity that's driving the type 2 diabetes. So I have a bunch of slides that I kind of put together over from several years of giving these talks. And there'll be somewhat surprises for Spencer. So I know the slides, I'll introduce them, and then we'll kind of talk it out, keep it pretty casual so people can ask questions at the end. You can throw comments into the comment box there. So first, this is a slide. I love the picture that you see on the left. That's actually from the National Lipid Association. Harold Bays was the lead author. He's one of our dogs. And they published this. This was actually focused on the dyslipidemia of obesity, but it was really a nice illustration about, adiposity, adiposopathy, as he would call it, and how it drives, especially visceral adiposity, drives the complications, including the insulin resistance and type 2 diabetes we're going to get to. But obesity, really it meets all the criteria for disease. It's been recognized as such for well over 10 years now. And recently there have been other calls for different nomenclature. I've been involved with the American Association of Clinical Endocrinology, which, along with the European Association for the Study of Obesity, has proposed a term called adiposity-based chronic disease to sort of encompass not just weight and the BMI-centric approach to adiposity, but what harm does it do? How do we stage the severity of it? And as we speak, the Lancet International Commission is preparing to put out a statement in a similar fashion, talking about preclinical or clinical obesity based upon the complications. Spencer, do you have any thoughts to mention on you talk about criteria for disease a lot. You debate people on Twitter all the time about this.
Yeah, I do debate a lot of people about the concept of obesity as a disease. I like that they gave a little bit of a definition, the criteria there. But there are a lot of people that just don't think it's a disease because obesity is a choice or a lifestyle. We can debate that, but regarding whether or not it's a choice or not, the pathophysiology is there, and I think we need to recognize, adipose tissue as biologically active and having these complications that you see right here in this picture.
Yeah, and we're going to get a little bit more into that. So here's just a little bit, and I even use this slide for patients, talking about it is still an energy in, energy out concept. It just has a lot of complicated physiology and pathophysiology that goes into it. We can't do much about our genetics, age, or sex, although I did have an elderly lady the other day say, well, I can do something about that. And I thought that was pretty funny. And but we live in this food environment with hyper palatable, high energy processed foods that overwhelm our body's ability to deal with it. We have all sorts of environmental triggers, medications, other medical complications, and then physical activity that we live in a society where we have reduced physical activity, we have injuries, and all this other stuff. And on the left, you'll just see some of the basic hypothalamic control of appetite metabolism. I have some more pictures coming up in slides about that. We'll talk about the peripheral signals that communicate for homeostasis, including leptin from the adipose cells, the GLP-1, GIP hormones, and amylin from the intestines and the pancreas, the ghrelin hunger hormone from the stomach. And then in addition to all those, the mesolimbic dopamine reward pathway, all throwing monkey wrenches into this whole process, working against people within the battles against their own genetics, epigenetics, the environment, and all the other obvious lifestyle factors. So I'm going to go to the next slide before I get Spencer in on this. So this is actually from one of our friends who is a leading researcher in obesity, Anya Yasserboff, out of Yale, who compares this complex energy balance regulation system to like a broken thermostat in a house. So you can see the set point for temperature is, maybe dysfunctional. And if we, is Felipe talking? Okay, I don't know. And so it's kind of like a broken thermostat. So this is another slide I show to patients because I think it helps them understand this sort of, we're not going to get into the debate about the set point or settling points, but here's a slide that sort of takes that thermostat aspect and puts it into the person, where we have the brain as sort of that central regulating mechanism with all those other peripheral signals in our obesogenic environment, and ultimately is working against us. Obesity protects itself. Spencer?
I was going to say, it's a misnomer when we talk about obesity as a disease to think that, oh, we can't do anything about it. That, well, I guess it's people will argue that, well, it's just energy balance. So it is energy balance, but part of the disease process of obesity is driving the excess energy intake that you see here with the dysregulation in the appetite centers of the brain, and of course our environment too. So all those things can be equally true and not mutually exclusive.
Absolutely. So here's another picture I showed people. So we have this complicated pathophysiology, but people do the things that they need to do to change the energy balance and lose the weight, right? They cut their calories somehow. They go low carb, they go low fat. We're going to talk about all these dietary strategies. They increase their exercise, their non-exercise physical activity. They're doing all the right stuff. They lose weight. But then what happens because of that pathophysiology is that all those satiety hormones go down. They don't work as well. The eating behavior from those physiologic changes causes us to have more hunger, less satiety. We have a preference for high calorie, hyperpalatable foods, even if we don't want to. Maybe we have a little bit of what's called metabolic adaptation, where our energy expenditure just isn't quite what it should be for that new weight. We have nervous system changes that work against us. And ultimately, the body, the biology for most people, not everybody, but then will drive the weight regain. And that's when you hear about people doing everything they know they're supposed to do, they lose the weight, and then they regain the weight quite often. And I know Spencer has a lot of experience with patients who have been through this at Weight Watchers, and I have, by the time they make it to me, they certainly have, dealt with this probably a few times.
Yeah, the other thing is that it's not just hunger and satiety. There's this concept of food noise. It's really the thoughts around food. And it's not just specific even cravings necessarily. It's just thinking about food. So imagine, I can eat a little bit less. My brother will eat vegetables and salmon till he
Most of the
gills. But other people, they'll have a meal and they're still thinking about their next meal. They're thinking about, and really anxious about it. So part of this can go up too with weight loss, and it makes makes it very difficult to lose weight and keep it off.
Yeah, and they're miserable. There's like symptoms that go along with this, right? That food noise that he just mentioned, they're miserable. So then let's talk about, so we have the disease of obesity, but also what harm is that excess adiposity doing? And so this gets into more genetic predisposition of how people's excess adiposity gets stored and what harm is it doing. And so if you look over on the left, that's that sort of classical pear-shaped adiposity storage, where our healthy peripheral fat cells are storing the fat. It's still a metabolic organ, but it's essentially a healthy storage of that adiposity. But when they meet what people describe as a threshold for the storage, and this is very genetically predisposed, then we start to store it ectopically, we say. So this is very relevant to lipidologists, because this is when we start storing in our muscle cells, our liver, our the visceral adiposity. There's intrapancreatic adiposity that we don't realize. That's part of the type 2 diabetes pathophysiology. That's what drives the dyslipidemia, the insulin resistance, and ultimately the common denominator of pancreatic failure and hyperglycemia. And we have some more slides on that.
Yeah, we had a discussion with one of our friends who had an endocrinologist, had a BMI of 45 or 85. This person came in, no signs of insulin resistance or type 2 diabetes. Whereas, I mean, everybody on this call knows, I mean, you can get, even different ethnicities or South Asian friends, they'll come in with a BMI of 25 and just florid insulin resistance that you see, low HDL level, HDL cholesterol levels, and everything that you would see.
Yeah, and in fact, we know that those who are relatively thin have low BMIs, but have significant abdominal obesity, and especially if they already have the insulin resistance, diabetes, and heart disease, those people have the highest cardiovascular risk when we're comparing apples to pears, so to speak. All right, so then this brings me to that concept of that adiposity-based type 2 diabetes, and then also what are we going to do about it, and how can we kind of reverse it? So on the left is one of my favorite slides from several years ago. You may have heard of the egregious 8. That was sort of updated to, or no, that was the ominous octet, and now it's the egregious 11. So all these different components of pathophysiology ultimately leading to that final common denominator of pancreatic beta cell dysfunction due to loss of beta cell mass and a reduction in the insulin. But in the case of adiposity-based type 2 diabetes, it really starts with the obesity and the resulting insulin resistance that we were just talking about. And so if anybody's familiar with Roy Taylor out of the UK, he's the one who's really been the driver for these intensive nutritional deficits for reversing or putting type 2 diabetes into remission. Easier said than done, basically eating vegetables and meal replacement shakes that we'll talk about later. But what essentially he's shown is that positive caloric balance with adverse genetics, really driving the insulin resistance, the ectopic hepatic triglyceride, ultimately driving the demise of the pancreas, having triglyceride in the islets, and then ultimately not having a good insulin response. I could swear I had another, there you go, insulin response to that ingested glucose, and having hyperglycemia. So, liver insulin resistance and ultimately poor glucose tolerance. Spencer, do you have any comments on this?
No, I mean, if you've seen this, the twin cycle kind of theory.
That's exactly what he calls this over here. So that's what we're going to try to treat here. And so instead of, I really like this slide that was just published a couple of years ago in the Lancet, because for so long, we have focused so much on treating the downstream effects of type 2 diabetes, when it's really the pathophysiology, the root cause is the obesity or that adiposopathy, causing all the downstream complications of obesity, but also the dysglycemia, the type 2 diabetes, and then those downstream complications that are most important for hyperglycemia, like macrovascular or microvascular complications, neuropathy, renal disease, neuropathy, and then of course what everyone here is really interested in is the macroscopic complications, atherosclerotic disease, strokes, etc.
Yeah, we're going to get into some cases here, but I mean, I'm just thinking back to residency about throwing people on sulfonylureas. I know there's a lot of people on here that know those drugs, and then obviously all of our antihypertensives and all these things, whereas you could just go a little bit further to the adipocentric kind of view and start treating all of these things
Yeah,
at the
get to
cause.
the root issue. So this is kind of a key slide that I really think is good looking. So then I'm just going to quickly go over how do we stage the severity of obesity, and we're talking about diabetes and type 2 diabetes. So that's already a severe complication. But here's some staging systems proposed by ACE that I've been involved with. And really, no matter what your BMI is, if you clinically have BMI, waist circumference, or body composition clinical evidence of excess adiposity, and you have the disease of obesity, if you absolutely have no relative or related disorders, diseases of obesity, then we're calling that stage 1. You have uncomplicated obesity. Stage 2 would be, say, pre-diabetes, dyslipidemia, hypertension, et cetera. Whereas stage 3 is very severe, at least one severe disease, and we'll call that type 2 diabetes. So today we're talking about diabesity. And so if you have obesity complicated by type 2 diabetes, then you have severe disease, and we need to be more intensive with our efforts, because the more intense or the more severe the disease, the more intense we need to be up front to get to the root issue and try to put it into a sort of a state of remission and reduce the complications. I think I'll get to this part here. So that just brings us to what are our weight reduction goals that we use as surrogates for clinical goals in response to therapy, because we don't really care what people weigh, right? We care about what harm is it doing, just like we've been talking about this whole time. And so we have lots of data on what types of weight loss or weight reduction correlate to the clinical outcomes that we want. When we start getting over 5% weight reduction, we start seeing improvements that everyone here knows, like triglycerides, improvement in hypertension, improved glycemia. But when we start getting over 10%, that's when we can really prevent diabetes in those who have metabolic syndrome, pre-diabetes. And then when we start getting over 15%, we're starting to be able to put type 2 diabetes into remission. Now, easier said than done without the right medications that also have glycemic benefits that we're going to talk about. But even in those studies from Roy Taylor using meal replacement shakes, if they're able to do that, despite the physiology working against them, they often are putting their type 2 diabetes in remission. And also, when we start getting over 10% weight reduction, that's really where we start to see the correlated cardiovascular risk reduction too. Spence?
Yeah, I was just saying, I mean, just a small little bit of weight loss, we all start seeing blood sugar improvements. So we're going to get into kind of the therapies, medical nutrition and exercise, and then medical medicines that show the spectrum of what happens here.
Okay. And so this is just going back to that 2-cycle disease and talking about getting people below that personal adipose threshold that we were talking about. Everyone's a little bit different genetic predispositions, but if we can meet that weight reduction goal in a nutritiously, especially with exercise manner, we're going to decrease the liver fat, decrease the pancreas fat, normalize the functional beta cell mass as long as they haven't gone too far down the line of having type 2 diabetes for a long time, and potentially achieve normal glycemia. So we are the docs who lift. And so we used to do a little monthly editorial for MedPage Today about lifestyle medicine. And something that we notice a lot of people out there, I know nobody here believes this, but people out there think doctors don't ever push lifestyle medicine. And yet when we talk about how every single evidence-based mainstream guideline has lifestyle as the first line, nutrition, exercise, sleep, all the things, it's always first line. It's every single time because the evidence is there. I mean, we're not making this up, but for some reason there is this mantra out there that we all don't push lifestyle enough. So we need to keep reinforcing each other to push it. And so let's talk about some nutrition. So I'm going to pull up some stuff that are evidence-based recommendations for treating obesity in general, and also then thus the type 2 diabetes, and we can throw in some nuance. So consider some of the patients you have. And Spencer, you can kind of think about, maybe some patient cases. I don't have any in here because I just figured we could use some as an example. But really, ultimately, we have to individualize nutrition plans, maybe use our registered dietitian friends. One of the first ways we want to do this is we want to create an energy deficit by reducing refined processed food intake and replacing with the quote unquote whole foods and dietary pattern prescriptions or meal replacements that help that. Spencer, your thoughts on some of the data of, the whole processed food? People like to debate the different things, but it's been
Yeah, I
studied pretty
mean,
well, and it's beneficial.
yeah, actually, one of my little memories that popped up studying for the lipid boards, I think it was the SAP questions, was talking about like, hey, it doesn't matter what diet you do as long as you create a calorie deficit. Now, people will say, well, no, it has to be the diet that helps you stay more satiated. So for some people, it may be reducing their carbohydrate intake, but I think most people agree that replacing more refined, highly ultra processed foods with more whole types of foods it's more satiating. It's pretty
Yeah.
easily
And
seen.
there's probably some other complicated nuances within that we're not going to get into, but I do have a
Yeah.
slide from Kevin Hall's metabolic ward study that we'll talk about next. So like you just said, creating an energy deficit from all sorts of different specific caloric and macronutrient prescriptions, low carb, low fat, we can go paleo. I don't know that I would tell anybody to go carnivore, necessarily vegan. We can let the vegans and carnivore guys debate that, but they all work in some way. But we'll talk about how we can compromise and individualize this. And also fasting. Every single dietary pattern you've ever heard of can be combined with the different types of fasting that people like to do. What do you think, Spence?
Yeah, I've had patients before that have tried to do chronic calorie restriction, meaning like they're just trying to eat whatever 2,000 calories a day spread out throughout the day. And then they'd go and they wouldn't lose any weight. And then they would actually try to shift all of their meals into a feeding window is what they call it, or they do kind of alternate day fasting where they'd eat a normal amount on one day, and then a couple days a week they would eat very few calories, like 500 calories. And like honestly, it doesn't matter. Whatever way to get people to eat fewer calories on average over the week is what's going to help people lose weight. I don't think there's anything magic about fasting when it comes to weight loss. That's what the data is kind of showing now. But it may be conducive to helping people stick to a lower calorie energy intake overall.
Absolutely. And we'll have a couple of slides on those. We can talk a little bit more about it. But then alongside that, physical activity, exercise, and really, I like to emphasize that this is really for the clinical benefits. When we're talking about diabesity, people with type 2 diabetes get glycemic, blood pressure, lipid, and overall cardiovascular fitness from exercise, more so than weight reduction. But certainly it is good for the disease of adiposity. And we're going to go through some basic recommendations for aerobic physical activity, resistance training, increasing our non-exercise physical activity, and reducing sedentary time. Certainly these have to be very personalized. And we're going to, at the end of the exercise part of this thing, talk about how we really need to prioritize the strength training. Hence we are shills for strength training. And now with surgeries and really good medications, people losing a lot of weight, we really want to prioritize that during their weight loss journeys to preserve lean muscle mass.
Yeah, I actually had a debate about this 2 years ago, or now it's a year and a half ago or so at the Obesity Society about basically is my opponent, John Jakisik, who's an amazing exercise researcher, was taking the aerobic training side, and I took the resistance training side. And I really think, I think most people out there is like, yeah, do some cardio and go for runs. But a lot of people, especially in the diabesity, a lot of people need to lose weight before they can even start doing more of that aerobic training, unless they're on a nice, like easy bike. So,
And even then,
especially
it's
with these,
hard.
it's hard. And with these new medicines, it's just, they're losing weight so fast. And we're going to talk about this, that like resistance training is something they can do and really get into. And I think it's really important to make sure they're keeping their muscle. So.
Yeah. And then just overall, I'm not going to get into this too much, but just a multifaceted behavioral therapy aspect. The best you can do, obviously, a team approach is always very helpful, using your resources. Diabetes educators, dietitians, exercise physiologists, psychologists, counselors, et cetera. Not everyone is fortunate enough to have all those tools, and our healthcare system doesn't always support those things. All right, so individualized nutrition stuff. So we talked about focus, we can do calorie counting, we can do meal replacement shakes, finding a way to personalize their caloric reduction, carb restriction, fat restriction, time restricted eating, alternate day fasting, and then of course quality control, and that sort of thing. And if you really think about it, I have another slide on this. All these dietary patterns can really be put into a Venn diagram. And so for this aspect, for weight reduction, ultimately they create an energy deficit for weight reduction, with other nuances coming after that. And I really think that none of these things should be mutually exclusive. Any individual can do all sorts of different aspects of these types of dietary plans, but we're going to talk about how adherence is really key. And I personally think utilizing our registered dietitians who are, thinking in the same manner as we are, have expertise in using some of these medications and surgery is really helpful. Spencer has a lot of dietitians on his team, certainly, that are do great work.
Yeah, something to help them just change their behavior and stick with it. It's not rocket science. It's just really facilitating that behavior change and helping them form those habits of whatever it is that's going to be conducive to reducing the energy intake.
All right, so just as an example, so here are some data. Now, this is a relatively recent big, basically pooled, it's a systematic review and network meta-analysis of the different macronutrient dietary patterns. The bottom line is they looked at all these different interventions: low carb, low fat, dietary, just basic dietary advice, DASH diet, Mediterranean, etc., compared to just sort of the participants' usual diets. A lot of randomized trials, 22,000 participants. The bottom line, yada, 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 they all basically work very similarly, the same. And ultimately, this includes blood pressure. Ultimately, when you lose weight, you improve your blood pressure and all the other complications. I'm just going to move on. So that's kind of the bottom line up front of all these different dietary things. So here's this inpatient metabolic ward trial that I like to talk about, from Kevin Hall. And this was at the NIH. And, these are small trials, but they're very highly controlled. And what they did essentially was, in random order, they gave people ultra-processed food versus unprocessed food, 14 days each, ad libitum, and let them go at it. And so what you see in the blue is the ultra-processed food that was provided, and the red, the unprocessed food. And here, the top panel has the calories per day intake that they measured, and this bottom panel is the correlated weight change. Now, these are very short, but they were, again, highly controlled and perfectly match, essentially, the sort of automatic energy intake difference with the weight change difference. I know Spencer's talked a lot about this with Kevin Hall specifically. And, a lot of people have debated some of these things, huge analyses of retrospective data, correlate processed food with unprocessed food and weight and stuff like that. And people like to debate, how do we really define these things? But to be honest, I think people know what processed food is.
I know. I mean, like, if you want to be lean like my brother, you just eat the salmon and vegetables all day.
Yeah.
If you want to be kind of lean like me, I guess you can have a hamburger on the other side. But no, seriously, I do think it's like, when you see the Twitter debates, and I know there's some people that are here that are on Twitter, that's like, there's some people will say, like, okay, you know it when you see it, like, obviously it should be studied. I think it's really interesting, but I think it's pretty intuitive. Like, when you eat some of these foods, it's easier to overeat them.
Yeah. And so I think this is important for patients to see, though, because it's like, look, they had as much as they wanted, and this is what automatically happened. So I do think this is pretty important. So that's why we share it. Okay, here's the adherence. So this is an old publication, but this has been consistently shown. This was the one years ago, 2005. Gosh, I was in med school then. I don't know how old everyone here is, but it starts to make me feel a little bit old when I say, oh, back in 2005, I was what was I, second year med student or something like that. And this was the big trial comparing Atkins to Ornish to Spencer's Weight Watchers long before he ever even thought about dealing with them, and zone diets for weight loss, and then also the estimated cardiovascular risk reduction. These were randomized trials. And on average, again, the weight change was very similar, despite what all the people debate about. And when they really looked at the adherence, that was the key to the energy deficit and the weight reduction.
Yeah, so it's always about adherence. That's why it's, with the dietitian supports and finding, whether it's fasting or any other dietary pattern, finding something that works. And it's really hard to do as clinicians on here when you have, if you're lucky, 30 minutes with a patient, but usually if you're in a primary care, it's maybe 15 minutes. If you're, I don't know, you get 30 minutes apparently, allegedly, what I'm told.
I get 40 minutes for a new patient and
40, 20
and
minutes.
20 for a follow-up though.
Okay.
But I'm lucky I have dietitians who I can say, hey,
Dietitians.
I just spent a couple minutes doing the basics. Please go into the nuance of this stuff with them. And I'm very fortunate. I have very awesome dietitians that work with me. And so it'd be great if everyone did.
Yeah, I'm lucky in that I'm all telemedicine. It's direct pay. They're paying $99 a month, but I have my dietitians and fitness coaches, and then I have a whole app and all the little things that help with tons and tons of touch points. But if you're seeing a patient maybe monthly, it can be really difficult if you don't have that support. So, but you can do the best you can to try to get them to adhere to some sort of pattern.
All right. So I'm just going to fly through a couple of these because I know people want to get to some of the medications. So here again, this is a big, systematic review, umbrella review of published meta-analyses of randomized controlled trials for literal dietary advice for weight management in type 2 diabetes. And my big point from here is that it ultimately comes back to creating an energy deficit that is the critical component to the weight loss with low calorie diets. And the meal replacement plans that have been studied are the most effective dietary methods for weight loss and type 2 diabetes remission. This gets back to some of those Roy Taylor. It doesn't mean, now the irony, of course, is that you could argue protein shakes are processed, but that's a semantic argument that people like to have out there. It just is true. So when people are sticking to a very intensive nutrition plan like that, they lose the weight, their diabetes goes into remission. They still have to deal with that pathophysiology of the obesity that's making it hard to do that in our environment, though. Spencer, any comments on this slide? I mean, that's basically the bottom line up front of that.
No, I mean, on Twitter, again, it's a lot of the low carb or keto proponents will get very upset, but it's like, look, I'm not even against keto. If you can get people to do a
No.
ketogenic diet,
And it's good
just
for glycemia. Don't get me wrong. Like in a glucose-centric manner, yes, we in endocrinology, we are always trying to find the areas of carbs and sugars that we can get them to cut down. I just don't want people to think that they have to be keto when we want them to eat vegetables and fruit and beans and legumes that have other benefits. And they're not going to be keto when that happens.
And not drink butter and put it on the ribeye.
Right. Yeah, which they do. All right. Now here's just the slide on the basic intermittent fasting and time restricted feed that we mentioned. Spencer kind of went through this already. There are different versions of intermittent fasting, the alternate day versus 5 and 2 kind of thing, the time restricted feeding windows. All these are just essentially ways to help people create that energy deficit, which remains the key. Overall, big picture, weight loss is equivalent when all these different ones are compared to continuous energy restriction, but they can be mixed and matched and help people on an individual basis. So he already talked about this. This is just a big meta-analysis comparing all this stuff that was recently published. I'm just going to get to the bottom line, all these different you can see it. There's no statistically significant difference of all of these different methods, and yada yada yada, like Seinfeld says. It doesn't matter. It just doesn't matter. And so this was a Venn diagram I published a couple of years ago, just looking at how there are a lot of commonalities between the different sort of
Did you lose connection? I don't have control of the slides. Let me see. He says his computer just died. He just texted me. And I don't have his slides. 1 second. All right, he says he's going to restart. But basically, he's going over the commonalities of all the different types of healthful dietary patterns conducive to helping people lose weight. And it's really cool. We've seen a lot of these things I've seen them in Lipid Spin, in the various journals, lipid journals. It, very a lot of the same stuff. I think we have a dietitian on here as well. Anna is in here. But things that are satiating, whole, unprocessed, and I think a lot of people can agree that vegetables and lean proteins are kind of the base of what we usually promote when it comes to helping people lose weight. And it's very lipid friendly, as all of our lipidologists here will appreciate. I don't know. My brother said he's going to come back here in 1 second. He's the one that's controlling the slides here. If anybody has any questions in the meantime, I can answer them. But I see Anna says, had a patient on the carnivore diet, went from an LDL cholesterol of 100 to 195 in 3 months. Yeah, it's very common. I was very active in CrossFit, not on any lipid lowering therapy at the time. Appreciate the encouragement. Yeah, it's interesting. I did a study on myself. I was actually drinking butter, putting butter on everything, and seeing how fast that could increase my LDL cholesterol. Mine went from 100 milligrams per deciliter up to like 170 within just a few weeks. So people can see very rapid increases just from their dietary changes and decreases though, which is really interesting. So we can get into some of those cases as well. Hopefully my brother comes back here. I do want to mention though, even in residency, thinking of treating patients at the root cause of their adipocentric view, from the adipocentric view, really changes the mindset of like, instead of what people think we do is just throwing band-aids at patients, it's really getting to the root cause, like my brother is showing there. So I really
All right.
like that we're doing. Oh, there he is.
My piece of garbage work computer just doesn't give me any warning and it
I,
just died. So
I think I went over the gist of the slide. I think we
yeah,
can all agree that these, high unstarchy vegetables and
yeah,
lipid friendly fats such as nuts and seeds and avocados are good.
yeah. All right. So now let's just crank through the exercise and get to the meds for people. So, really, exercise is medicine for everybody. And there was a publication that I'm showing you right here from a couple of years ago where people were. It was kind of a debate thing, and they were saying, "Oh, well, it's such a vicious cycle." You can hear me, right?
Yeah.
What is going on here? That they acted like it was a futile thing. But my argument would be, let's do both. Let's treat the nutrition. Let's use medications for weight reduction, and let's use exercise for the health benefits, because exercise is really really good for health. I think that's kind of the key of what I want to get across. Aerobic activity, resistance training, non-exercise, exercise, because reduces mortality secondary to obesity. We have improved cardiorespiratory fitness, etc.
Are you able to
Okay,
advance the slide? It looks like
wait, can you?
it looks
Oh,
like the slide's still on the Venn
is it?
diagram.
Can you see it or not?
I can see the Venn diagram, but
Oh no,
it's not showing the.
it's sharing the wrong thing. Hold on. Darn it. Sorry, guys.
Yeah, the coconut oil, Shannon. Yeah, the coconut oil. People think it's healthy, and they'll pour that along with their butter into their coffees. It's
All right. Can you see my slide now,
yeah. There you go.
Spencer? Oops.
Oh, now it's gone.
Oh no. What the heck? All right, I'll go
There
back
you
to
go.
this. All right.
Let's
This
see.
was that futile cycle that somebody published. You see that? What I'm talking
Yeah,
about?
yeah, yeah.
Okay. Anyways, we don't need to get into the fine details of this. We need to do exercise for the health of it. Here's some of the goals that like that are just in the 2024 ADA standards. These are very consistent throughout all guidelines based upon the evidence we have. It's just easier said than done to get people to actually meet these goals. But basically, we want to get people doing some aerobic exercise, resistance training, and reduce sedentary time. I mean, these are all so obviously evidence-based that they're in the most mainstream guidelines we have. And so I do want to point out that the reason I talk about health so much as opposed to weight is this waterfall plot in the top right over here. I describe this to patients when they say, oh, I know I just need to exercise more. Well, exercise intervention doesn't really lead to a lot of weight loss. And this was part of your debate, Spencer, with John Jakisik. And so when you look at these waterfall plots, those represent individual weight reductions on the same exercise intervention. Because of that obesity pathophysiology, some people do lose a lot of weight, but then some people have like overcompensation for their energy intake, and they actually gain weight. Now, hopefully, some people gain some muscle, but everybody gets health benefits. And in diabetes, we have glycemic benefits, lipid benefits, blood pressure benefits, and really it's hard to do this in a randomized trial, but we certainly see mortality benefits, cardiovascular benefits, et cetera. That's really the primary goal.
Yeah, just a clinical thing. I would try to rebrand exercise because, yeah, I'm sure everybody in here has had patients come in. I think I just need to exercise to lose. And they got a BMI of, let's say, 35, 40 or above. And it's like, exercise isn't the problem. We want you to exercise, though.
Mm-hmm.
So
Yeah.
Rebranding it, trying to help with expectations because they're going to be really upset when they start working out really hard and the weight's not coming off.
Yeah. And so I'm just going to go through some of these, just, getting people to find a way, get that eye of the tiger back. All right, so let's talk quickly about, we only have about 15 minutes before questions. So some of the medications that everyone's interested in. So we're not going to talk a lot about orlistat, over-the-counter ally, brand name Xenical. It's a fat absorption blocker, is around. We used to have lorcaserin, which is a 5-HT2C receptor agonist that had very modest benefits. It got taken off the market for some concerns that we won't get into. We've had liraglutide, the GLP-1 receptor agonist, out at an obesity-related dose for a long time. We've certainly had it out even longer for type 2 diabetes. The phentermine topiramate controlled release for long-term management. We've had phentermine theoretic or technically just indicated for a few months at a time for a really long time, but studied for chronic management now. Naltrexone bupropion extended release. We had the Gelesis, the hydrogel. It actually is not available right now, so I'm going to take that out of there. We have the weekly semaglutide with the brand name of Wegovy that has become very popular now, similar to the Ozempic dosing for type 2 diabetes. And of course, we also have tirzepatide, somewhat recently approved for type 2 diabetes and very recently approved for obesity. So this is actually a slide from pediatric guidelines. I just like it because it kind of shows where all these different medications work, even the single molecule like the naltrexone and the topiramate that are used in combination with bupropion and phentermine. Just looking at where they work. Mostly we're talking about up in the brain in that hypothalamus area with the POMC, the leptin receptor, POMC, PCSK1, leading to alpha melanocyte stimulating hormone to the MC4 receptor. You don't have to memorize all that stuff, but just understand that's kind of the pathway of how all these medications mostly work, other than the GLP-1 receptors also being in the brain stem, and now tirzepatide, which is a GIP GLP-1 receptor co-agonist, which has some of the best efficacy we have. Orlistat is the different one. It works in the gut, doesn't work up in the brain. So just a quick little comparison. I like to show this slide because it compares liraglutide to orlistat and placebo. So this was a small trial several years ago where they randomized to the different doses of liraglutide, placebo, and the high dose orlistat known as Xenical. And then they did an extension. And what you can see here is the separation really seen for the weight reduction. You can see here the mean weight change in kilograms, which is always similar to percent, because it always seems like about the average weight is around 100 kilograms in these trials. And then you can see at 52 weeks, the consistent separation of the high dose of liraglutide, getting somewhere between 11 and 12 kilograms of weight reduction, compared to the orlistat group, which got about 7 kilograms of weight reduction. And this had a good lifestyle intervention, by the way, because if you see, the lifestyle intervention got over 4 kilograms. That's actually more than most trials with real basic lifestyle intervention, which only gets about 2% weight loss. And then what they did after that is they crossed everyone over to either stay on the orlistat, you can see in the green, or the getting the 3 milligrams of liraglutide. And so that really just gives you an idea of the orlistat. We don't use it that much because people don't like to have oily stools and oily flatulence a lot. But it actually does have a lot of benefits for. It has some glycemic benefits in type 2 diabetes. It has lipid benefits, and it actually has. It's actually good medication. It just has it's a pain in the butt to take 3 times a day with side effects. Spencer, you have any comment on orlistat? Because I'm going to move on for the
No,
GLPs.
I mean, no, we'll talk about, when we use the orlistat, we use a lot for those with GLP-1 induced constipation.
Yeah.
So it
Yeah,
actually evens
absolutely.
it out. And then there needs to be a trial on this, but I'd imagine that they'd lose a little bit more weight with it, but it
Yeah,
actually evens things
sure.
out.
Absolutely. And so then that brings us to kind of the big liraglutide trial in obesity and pre-diabetes. So this is not in type 2 diabetes. There are a lot of data on liraglutide in that. But just to give an idea, this was 4,000 people randomized to liraglutide or placebo. You already saw the orlistat compared to liraglutide. And basically it was about 8 versus 2.5% weight reduction, which, going back to how much weight do we need to lose to have clinical benefits, this gives you an idea. Here's the categorical weight loss. So we really want to start getting, especially in diabetes, but now type 2 diabetes trials, people don't lose as much weight. So in obesity and pre-diabetes, people do lose more weight. So just have that in your context when we look at some of these other trials. But a third of people were able to lose more than 10%, and 14% were able to lose more than 15%, not many people in the placebo group. And here's just I'm going to go through this because it's all about response to therapy. So almost 80% of people were able to get that 4% weight reduction that you hear about for the early response. And of those people, they went on, to get, they went on to have really good response. Now, only less than a third of people in the placebo group got that 4%, but even those people ended up having about 8% weight reduction, which is very good. Just a far fewer people were able to get that early response to therapy. But this is a way for all these medications to tell if people are going to have long-term good response to therapy, and why, especially for the older medications, those are the initial goals to even continue on the therapy. I like this trial, even though it's liraglutide, and we're going to talk about semaglutide and tirzepatide, because these were people who only could get into the trial after they lost weight in a run-in period with diet and exercise. And so these people lost about 6% of their weight, then were randomized to placebo. As you can see, they responded to their own lifestyle. So they maintained that weight loss pretty good. But then they were randomized, the other people were randomized to liraglutide, and they had an additional 6% weight reduction. Here's a little key nugget in here, is that when they stopped here at 56 weeks, what do you see, Spencer? Tell them what they see.
You only have a few minutes before Q&A. You better get to the
Oh my God. All right. Oh my God. Okay. All right. All right, so let's talk about liraglutide versus semaglutide. And again, this is without diabetes, but it's a small trial just showing you the difference between it. And the bottom line here is that there was about a 16% weight reduction with semaglutide versus 6.5% with liraglutide, 2% with placebo. And again, it's not as much in people with type 2 diabetes. All right, so I'm going to blow through this basic semaglutide trial here just to show that a lot of people were able to participate. or to finish the treatment, so they weren't dropping out due to side effects that everyone thinks they get. And they had a 14% placebo subtracted weight reduction, which is very clinically meaningful. And when you look at how many people were getting 10, 15, and even 20% weight loss, that's a lot of people seeing very clinically meaningful benefit, preventing diabetes in this case. But in step 2 and some other trials, they looked at these higher doses of semaglutide in type 2 diabetes. This one, they randomized 2.4 versus the one that was previously approved as the high dose for type 2 diabetes. They had an A1C of 7 to 10%, and they all started about an A1C of 8%. They were on other medications like metformin, sulfonylureas, and what basically see, we're talking about weight reduction here, 4.5% more weight loss than placebo with the 1 milligram of semaglutide, but another 3% weight loss with the 2.4 more than the 1, and really a better A1C reduction and fewer other type 2 diabetes glycemic medications. Basically, semaglutide 2.4 is very good for weight reduction, pretty good for type 2 diabetes. It has its own glycemic benefits, has good safety and tolerance overall, improved glycemia, improved lipids, improved blood pressure, physical function, and really not a lot of adverse effects like people think there are. Nausea is very common. We have ways to help mitigate that, and people are always afraid of pancreatitis. In the big, huge meta-analyses, all these medications for type 2 diabetes really just haven't shown a significant concern of pancreatitis. But there is a little bit of increased risk of gallstones, which can cause pancreatitis. Spencer, any comments on that quickly before we go to
we
tirzepatide?
do, and we do see that clinically. I mean, again, I have tens of thousands of patients I've overseen at my clinic, and we do see it from time to time, the gallstones, and people have to get the gallbladder taken out, and once in a while pancreatitis from the gallstones.
Yeah. And so then that brings us to the tirzepatide. This is the GLP-1 GIP receptor coagonist. Is there a little bit of extra weight reduction from metabolic rate as seen in the animal trials? I'm still a little bit skeptical, but we're going to show you why or how it has been shown to be the best, most efficacious medication we have for people with obesity, other than very specific medication for genetic obesity. I'm going to go through this stuff a little bit. We'll have these slides available for you. These are just some of the overall thoughts on benefits of how this medication works. Here is a big look at the type 2 diabetes trials for tirzepatide, since we're talking about obesity with type 2 diabetes. You can see in the green, this surpassed 1. These were people with somewhat early type 2 diabetes, only 4.5 years. In the orange, surpassed 2 and 3. They had more established, over 8 years of type 2 diabetes. You can see their A1Cs all about 8 or over 8%. And if you look down here, this is the change in A1C. So they're getting 2% A1C reduction with tirzepatide, and we haven't even talked about the weight reduction yet. If you compare it to the semaglutide, you can see even all doses of tirzepatide, 5, 10, and 15, getting more A1C reduction than even the semaglutide, which is really good at 1.9% A1C reduction. Certainly far better than titrating basal insulin like degludec to fasting blood glucose goals. And we're going to talk about how
the Q&A. You're
oh
getting
my
yelled
God.
at.
I am?
Yeah, you're getting yelled at right now.
What? Yeah, I didn't hear anybody.
Kathy's yelling at you.
Kathy, what?
Yeah, we gotta go to
look
we gotta go to Q&A.
But look at the weight reduction.
Wait, hold on. Before we go
open
on,
up the Q&A.
Before we go on, just think intense, like gold standard exercise and lifestyle, 5-7% in the randomized trials. Liraglutide 3, maybe 8%. You get to semaglutide 2.4, you're seeing that 15-16%. Now tirzepatide is at that 21, and even if you extend it longer, maybe up to 25% weight loss. You go to bariatric surgery, now we're starting to see in 25, 30 and above. So we really meet that treatment gap. That is just an important thing. Also, people want to know, do I have to take this for the rest of my life? Most people will. 80%, here's a good slide, but 80% of people in these trials will keep, or 20% of people, 15 to 20% of people will keep 80% of their weight off after they stop, but when they switch to placebo. but this stuff needs to be studied longer. I think those are kind of the
Yeah,
main things.
and here's the slide on that. This is the Surmount 4 trial. Now, this is with obesity, not type 2 diabetes, but they all got tirzepatide. At 36 weeks, they had 21% weight reduction. Then they were randomized to either go to placebo or continue tirzepatide. If they continued tirzepatide, on average, they got another 5.5% weight reduction. But unfortunately, the people randomized to placebo, they had a 14% weight regain.
Okay, we should answer
All
some
right.
questions.
All right. See if you can. I don't think I can see the question. So if you can
Okay,
see
let's
them, go
see.
for it. And I have
All
more
right.
slides if we need to talk about them.
Okay, Stephanie goes, what's your experience with suicidal ideation and with these medicines, GLPs, GIP combinations? What about patients with mental concerns? So we monitor everybody. We do our PHQ 2s and 9s if we need to. We haven't seen any suicidal ideation. I think there was one patient who mentioned like there's something going on here uh,
Yeah.
with it, but the recent FDA, they looked into this
Yeah.
and
And the European, the EM,
honestly,
and
like
it's not statistically significant, but we've both had patients who say, I swear to you,
there's some who,
it caused something and I stopped it and it got better. Very
yeah,
few, but a
very
few, a
few.
few.
Monitor patients just like any medicine,
Everyone needs to be monitored,
these
right?
medicines are
Yeah.
working up in the brain and they're decreasing that reward behavior, which in a lot of people can actually improve their anxiety and things, but it's possible it's dampening some other people a little bit um more than what we'd like. But
Mm-hmm.
it's rare, but you should monitor. Janet, my exercise comment was, Janet mentioned before, a lot of patients don't know how to push themselves, which is why
Mm-hmm.
I think it'd be great if you could have a physical exercise physiologist or a trainer with somebody. But yeah, I agree with that. Someone mentioned
Yeah, but I'll say
protein.
you don't have to push. They don't have to push it. They don't have to work out at a high intensity,
No,
but
but
they
like
need to be doing it.
higher than
You
just
know?
like doing some reps and being able to walk, talk
Yeah,
and whatever, but a
yeah.
little bit
It
more
would be
than that.
nice, but yeah.
Um, Oh, what's the lean muscle mass loss? So in the
Oh,
when you look at
that was the
Surpass
subgroup of semaglutide.
yeah, so Surpass and Step One both have the signal with DEXAs. Now, DEXA scans don't look directly at muscle. It's they see lean mass, and it looks like a 38 or so percent decrease in lean mass, which is a little bit more than what you'd expect. But like what they don't know is whether it's actually muscle or not. Tirzepatide's more like 22, 23 or 4%, which is kind of in line with what we'd expect. And so I was just with some of the step trialists this weekend, kind of talking about it. I don't know why nobody's studying this, and maybe they're scared. What I do
We
think,
tried.
though,
We tried
like
to
we
propose it.
did submit it, but tirzepatide doesn't have the signal. Is there something about semaglutide that's catabolic? I don't think so. A lot of my patients get stronger. They're
Yeah.
so much more physically active and functional. But again, it's a
And here's the
selection
bottom
bias.
line. We are shills for resistance training. We want everyone to have as big and healthy muscles as possible. But if you look at all those trials for semaglutide, if they are losing muscle mass, what else is happening? They're having reduced cardiovascular events. They're having improved glycemia. They're feeling better. Their life is better. So let's get people to do some resistance training and
Yeah.
minimize that. But the clinical benefits are there regardless.
Yeah. Stephanie goes, would you give a patient either with a family history of pancreatic cancer or with a known pancreatic mass themselves a GLP-1? Yeah, pancreatic cancer, I'm not worried
Yeah.
about. You would want to make sure that whatever the
If,
pancreatic mass
I
is
was going to say
benign,
that's a whole other. They need to get that addressed,
but
right?
not
Regardless,
it's
but
not a
it's not
contraindication.
right.
Even pancreatitis technically isn't a contraindication; it's a
No,
caution. So, what we do caution about is idiopathic pancreatitis, and this is a medical legal thing. Imagine the patient has another bout of idiopathic pancreatitis after you started this medicine, and they try to sue you. I wouldn't mess around with idiopathic, but if they have gallstone pancreatitis, you took out their gallbladder, they're
or
good to go.
triglyceride pancreatitis,
Triglyceride,
and we're fixing their triglycerides with the
right?
medicine.
So we didn't have enough time to talk about it, but I was going to make a comment. I love all the new lipid trials with like the ApoC3 and all these different things, but it's like, gosh, unless they have familial my but whatever. I'm not even speaking about, but whatever. And it's a familial issue. Like if you treat adiposity, you'll reduce their triglycerides. So like a lot of these
Yeah.
patients, like 500, even up to 1,000, I'm putting them on tirzepatide. Sometimes I add a fibrator fish oil, but like oftentimes you can get them off of those quickly
Yeah.
once they reduce their adiposity.
Absolutely. We're treating the underlying root issue of the type 2 diabetes and dyslipidemia. What else? I know we're at 8, but what other questions?
I was like familial chylomicronemia,
Chylomicronemia, is that what you're talking?
chylomicronemia,
Yeah, or at least some version of it. Yeah.
FC.
What other questions, Spence?
Let's see, anything else? I mean, I think the main thing
I'm just
like,
going through and showing some of the data on Qsimia so people at least see it, see what the differences are.
some people want to know about protein. I mean, we try to put like up to 1.2 grams per kilogram. If you can go a little bit higher, but some of these people, if they're 300, 400 pounds, do they need that much? Probably not.
Right.
It's
No,
probably more based on lean, their lean mass. But
yeah, and it's not as important as the resistance training, by the way.
is so important. Yeah.
We have a podcast episode on that, by the way, for those interested in our Docs Who Lift podcast. We have a whole episode on protein requirements with like the global guru on protein.
Right. Yeah. Sorry. I mean, we could probably do a whole nother thing on medicine. We had to rush the medicines at the end, but
I got a question for you guys.
Yeah.
Are you guys using HOMA-IR scores or OGTTs to identify these at-risk people before their A1C goes?
So I do a lot of OGTTs, but I'm in the endocrine clinic, so we do a lot of that anyways, because we're trying to, to see if we can diagnose type 2 diabetes. So, we're looking at fasting glucose, A1C, OGTT. To be honest, when I was a med student and I did a lot of rotations with endocrinology, that's when I first learned about the HOMA-IR, and it seemed really cool. We didn't have anything back then. We didn't even have, we had exenatide a little bit, but we weren't getting it off label. So I remember people going, yeah, maybe you can give some metformin to these people. But really, as it's turned out, it doesn't really change what we do. We can do it if we think maybe it's going to cause the person to say, oh, I have some insulin resistance. I just don't have any dysglycemia yet. But, we can tell if people are getting insulin resistant. So I do it once in a while, but it's usually only if the person wants to, or if I really think they need something to show that, hey, you got disease cooking that's not just healthy, benign obesity, which is not benign, by the way. But that's a whole different topic.
Same.
Yeah. All right. I know we might kind of met our hard cutoff. So I know that's a lot of information. I always get asked to do what I consider requires a lot of information to talk about in 1 hour.
Yeah, because you can spend a whole hour talking about specifically the meds or even one of the medicines.
Or one medicine. Yeah, absolutely. So
there's some really cool, and for the future, these new glucagon receptor agonists.
Oh yeah, they're the triple Gs and
there's some really interesting LDL cholesterol lowering ability of these. I mean, it's really interesting to see, and they hit the receptors differently and then have different downstream effects, which can then change what happens. So I think we're going to see some really cool stuff, and the lipidologists in here will have a lot of tools coming in there for their toolbox.
Hey guys, Greg Pokrivka here. Nice to finally meet you guys. And
thanks.
That was a great talk, but we're going to have to sign off. And I just wanted to thank you guys. This was you did a lot in 1 hour. That was fantastic. I'm about to go grab a protein shake myself.
Good deal. Thanks.
All
right, guys. Well, we're available for questions. Our podcast is available.
Thanks a lot, guys.
Slides are available. Right. Absolutely.
Take care.
Bye.
Take care, everybody. And I don't know when the next Sela Speaks is. Kathy, do you happen to know when it is? You want to unmute? Tell everybody. Kathy, if you're still here. Well, we'll send it out.
I'm here, but I'll make sure I send that out. Okay.
Okay. All right. Thanks a lot, everybody.